Hello. Thank you for coming to the presentation and for having me participate in this seminar series. I want to thank the faculty for the opportunity for being here as a fellow and also the organizers of the seminar. It's been a very interesting first seminar, and I hope this presentation also contributes to the discussion that we are interested in. My work is about obstetric violence, and it's coming from a research I've done in 2017 and 2018. I really appreciate the opportunity of being here because since then I've moved to work in the public health ministry and do policy and administrative work. So this is a really great opportunity to go back and read again, do research again, and think in a more academic environment and setting. So it's actually a very good opportunity to rethink the information and the data I've collected. So let me start with the picture. This is a picture of young women in the Amazonian city walking while in labor, waiting to be admitted into the surgical room once it's time. In this photo, she is accompanied by her partner and mother. Once she moves into the room, she will be alone with the health practitioners taking care of her. So that's one characteristic that is still very common in most public hospitals in the country. So I'm just going to mention the points that I want to present here, a little bit of the background on the project itself, that is a much bigger project, a little bit of the Peruvian context regarding maternal health, maternal mortality. I'm using the typologies of obstetric violence as a guide to analyze the discourses and the practices and the narratives of the health practitioners. Then I'm going into the cases and the experiences of the practitioners themselves, and then open up for discussions and bring some of the experience, discuss some of what those experiences tell us and can tell us about obstetric violence. So this project was an interdisciplinary project funded by a consortium of university fund in Peru that looked at the process of medicalization of birth and how that process might be influencing, or how is that related with violence against women during those processes. It comes from, the team was made by historians, anthropologists, and public health specialists. So we try to look at different kind of sources and information, and for a long period of time. The data collected explicitly on health practitioners was in that period of time. At that moment, there was a lot of literature in Latin America about obstetric violence. They were starting to be discussed, especially from feminist movements' approach to violence against women in general, and obstetric violence in a specific aspect is being conceptualized. Since then, there's been much more research and publications on the topic. So a little bit of what happened in Peru. Peru has been one of a successful case to some extent in the period of achieving, or the process of achieving, the Millennium Development Goals. So we reached the goal for 2000 regarding reduction of maternal mortality. There were a lot of funding to increase, especially prenatal control interventions, institutional deliveries, and two of them were the main interventions. So by 2020, 90%, maybe somebody in the Zoom has the microphone. Okay, so by 2020, more than 90% of deliveries were taking place in an institutional facility or by a health practitioner license. But at that time, it was really penalized even in an informal way if women were attended by local midwives or in their houses. Okay. Okay, I'll just leave it there because here is also connected.
Yeah, just click a minute so then you have to kind of get people to know.
If you close, you're going to close this one.
I'm not going to close that.
Okay.
What this?
Okay.
Should I close that?
I don't think so. Maybe you can close there.
Are we still in the call? We're still in the call?
Yep.
People can still hear us? Yeah, that's good.
Yep. Okay. So that's a little bit of Peru. There was an increase in health deliveries in institutions, so that was good. There was an increased access for women, more in the cities, less in the rural areas, of course. The internal disparities are still very high, but the reduction of maternal mortality continues. So that was a success, and it has been continued until now, pre-COVID, and encourage most of the policies that were developed. So what happened then? In the since 2016, with all the encouragement and the advocacy work from feminist organizations and the campaign to prevent women from suffering violence, the National Plan Against Violence, in general, made a chapter about obstetric violence. So it got into the legislation. And it was defined as a specific form of violence taking place in institutional spaces, performed by the health system, and as a form of domination and control over the body and autonomy of women. So it was really good. It was, again, a success about that, a success from the women's demands. The WHO organization also began acknowledging the problem, doesn't call it obstetric violence, but includes the concern for the disrespect against women through pregnancy. There are demands and bodies, the Osborne bodies, that are collecting and making claims about that, and there is an observatory of obstetric violence that is supposed to collect information of cases against violence. One of the first problems that we found is that this observatory is supposed to be filled by the Ministry of Health from their own cases. Of course, there's no cases of obstetric violence reported by the Ministry of Health, performed by their practitioners. So we start to find some gaps there in what are we moving towards. Then what I see to try to understand how can we approach obstetric violence in a way that can give us some grounds to make some changes or to understand it better, I looked at the literature on typologies of obstetric violence. And there's two key ones, one by Bore and collaborators in 2015, and the other one by Castro and Savage in 2019. They're very similar in the issues that were identified, mostly classifying experiences that women have reported and through several research performed in different settings, in Latin America mostly, but also in other countries of the world. And what I find is that the only disparity or the only big difference is in terms of the physical abuse and the failure to meet professional standards of care, right? In one case, physical examinations are seen as failure of professional standard of care. In the other one, they're part of or considered physical abuse. But they're accounted for anyway. So what I wanted to see is how health professionals relate or understand or identify within these typologies. Like from the perspective of women, there is more or less consensus. The social sciences also agree with this. From the WHO, they acknowledge there are some indication, but they can't quantify, they can't measure, there's no prevalence about these problems. So I moved to see, well, let's try to approach the issue from the other side. What we did was, well, they conducted the interviews that I mentioned at the beginning. The study passed an ethics committee, and we asked health practitioners about experiences that they had during providing the care that they felt very positive and encouraging and a very nice experience that they could recall, and also very negative or problematic experiences that they had felt while taking care of the women and making the delivery. We didn't want to ask about obstetric violence or abuse because then you start the discussion in a different position, like accusing them or framing it in other discourses. So from that question and from those narratives is that we start to analyze what do they think of obstetric violence. We had 20 interviews in total. Midwives, obstetricians in Peru are not doctors, right? Are between nurses and doctors. Maybe here is the same. Mostly women, and they are not allowed to attend a delivery in an institutionalized setting if there is a doctor. So they are only attending when there's no doctor or nobody else can take care of women. So one of the main or the key quotes that organize again or makes my claim relevant is this one that a midwife said in one of the interviews. It's like she was telling about an experience that she said, for us, attending is examining or seeing that everything is fine, that the child is born healthy and everything is okay. So I'm taking the measures. But for them, for women, attending is having someone to comfort them, someone to be by their side, someone holding their hand. And we don't really do that. So we are, from one side, claiming and demanding and developing a series of bodies of legislature to demand some things with what women want, right? What we want as care. And meeting in the other place a different understanding of the problem. So what do they understand as problematic or not problematic? I have a few quotes here about positive experiences. Most of the positive experiences that were described became from or were related to overcoming a complication and finally delivering a live baby, a healthy baby, and a live mother. Right? It's very important to point out that the mother is alive. Right? It's more concerned. The concern is more about the baby being healthy and the mother being alive. Right? So that's also a nuance there that you can read in the interviews. So other expressions that midwives mentioned is like it's a nice experience, or they are very happy about the process when women collaborate with them. Right? What means to collaborate? That they don't scream, they calm down when the midwife goes and said, okay, calm down, and try to make their effort, seem very empathetic with them, and they respond, and women respond, right? So that it's a very nice experience, and especially when women allow midwives to do their job, right? So they won't be complaining, and they will facilitate and accommodate their work. For OBGYNs, who are the ones that are actually performing or delivering the baby after the period of labor, most of the positive experiences relate to the experience of the family receiving the child they give them, I will say, right? They deliver the baby and handle it, present it to the family and to the mother, and the family receive the baby and are happy to receive it, and it's a wanted baby, right? So that's very much some of the issues that are commonly mentioned. And there's one there, like there's very emotional and very sensitive about those cases, right? A negative experience then. Negative experiences tend to be related to the opposite, having a baby that's not healthy, that dies in the process of delivery. Also, the situations in which the babies are not wanted. Right? So health practitioners recall and remember those situations in which the mother, for example, is not happy to receive the baby. There are some quotes in which they deliver the baby and they show it to the mother, and the mother doesn't want to see it, right? And they have to, by law, show it to the mother, right? The protocols. So there's a midwife that tells her assistant, show her the baby, and she's saying to the woman, look, it's your baby, it's nice, look at her, give her a kiss, it's pretty, and the woman is clearly turning her head back until assistant and midwife look at each other and said, okay, don't insist anymore, right? And the midwife at the end in the interview recognizes, I didn't know anything about the woman, of her history. I later learned that it was a product of rape. So the woman didn't want to see the baby. And then I'm not here to judge, I don't discuss, but I have to show it I had to try to and show it. So we have those cases in which they don't recognize, for example, that as violence, but it's part of the protocol that they have to apply. Also, they recognize as problematic when they have difficult relationships with the patient or the family, meaning they are asking for questions, or they're not cooperating, or they don't follow the instruction of the practitioner. stories about health practitioners having problems with other health practitioners, right? Especially midwives and medical doctors, but also within the hierarchy of the institutional setting, right? That's common. And also there are many stories in which they have problems when they don't have the control of the situation, right? For different reasons. For example, the delivery comes too quickly and they weren't ready, or they react in some way that they didn't expect it. So it doesn't have to be necessarily because of the women per se, or the relationship with the women, but that there's something off and they are not in fully control of the situation. What was interesting is that even is a small sample, only 1/3 of all the experiences that people mentioned referred explicitly to the feelings that the pregnant woman or the women in the delivery room were having. So the experience was negative, was wrong, didn't give them a good sense because of their own experiences. Right? To some sense, makes sense because we were asking them for their own experiences, right? But if you see the attention or the care as an interrelationship, you would expect that some of those bad experiences will have some mention to the other key actor in the room. So what kind of violence, or what types of violence can we identify in their experiences? The one here I have is a medical doctor that says, well, yes, we're asking for a negative experience, right? And says, well, when they don't feel comfortable, right? And there are several situations of those cases, from patients who are uncomfortable being examined with a certain periodicity, but it's part of the job, right? They mean the I don't know how to say that in English. The vaginal touch, vaginal examination, when they have to do it every 10 minutes, apparently, in some cases. So they understand that's something that makes women uncomfortable, but again, that's what we have to do, right? So at least there is an acknowledgement there to some extent. Then another situation in which they understand or are aware of the violence that they might cause is when, for example, this female doctor is doing the rotations in the public hospital, and she was a student taking the course of surgery, and they have to do the practice in the hospital, right? So she has to perform the episiotomy in the delivery, and she recalls that it's something that she felt really aggressive or violent, right? She, as a doctor, here in this quote, she's mentioning talking about obstetricians, midwives, who are the ones that do that, right? Or how she separates herself from different people that does the violence, right? So to some extent, she's not aware of that she doing that, but that it happens and it's somehow common in the process and the situation. Another example here has to do with the Christeler maneuver, and there's another example here I can read. This is again a student that is in the room, is having to take the classes, and she said the doctors are coming and going, everybody is trying to help the woman doing the Christeler maneuver, which she said is crushing the abdomen of the woman. I was desperate, trying with all my strength to do the maneuver. And Mrs. Push was what she recalls telling her, and I swear I came out sweating in the process. And she recalled that she couldn't understand it anymore, but the process continued, and she didn't understand why they don't transfer the woman for a C-section. And for a moment, then she realizes, or she thinks she realizes, that it was pressure from her obstetrician teacher, right, who was saying no, that she has to continue the process, the baby has to come out, and that the student had to deliver the baby, which was part of, I don't know, an exam or part of the training, right? And that happened, right? So it finally was delivered. This student made the cut, she says, and then she had to take the baby out. Here there's no mention at all of what would be happening with the women in this process, right? But the midwives recognizes that she was feeling sick, bad, right? Following the conversation, she mentioned, I felt really compelled and really sad and furious, and I think it's the first time I felt that I was mistreating these women, right? She felt mistreated as a student, and she felt the women was mistreated. So there was one explicit mention of the violence she heard. Then we have another examples. These are not necessarily acknowledged by the health professionals. They don't explicitly mention that they understood them as violence, but it's part of what they have to do, right? And it has to do with loss of autonomy, to mention one of the categories of violence that we could attribute it to. So this is the case of a woman who is in her 4th C-section and does not want to be, we say tied up, but legally, her tubes tied, or her, right? Sterilized. She doesn't want to be sterilized, right? And this OBGYN says for the right to safeguard her life, so the women's right of life, they need to tie their tubes, right? Even if she presents a complaint, you have legal support. They said. Why? Because if the mother dies, you have a whole explanation, right? Her children will be left hopeless, and there's sufficient legal justifications to do this, and they have to prevent it. So there is many issues here that violate many women's rights according to the law against violence against women, but it's not part of the protocols, and even national health guidelines support this position, right? So they are a contradiction within these legislations as well. We also have other example, I haven't write it here, of a doctor that says, okay, we have to, it's not that doesn't get this far, but it says they come up of the delivery room and we put them the 3 months implant. And it's the same argument. Like, we have to. She has to come out with the implant. And they convinced her and said, you will come in 3 months and we will put it again, and you will understand and you will know that it was best, because now you live with the 3 months and you will finally realize that it was the best what we could do, and we will be doing it again. This other person says, we can't go and do sterilizations because that's too much, right? But we have to do something because they can't have more kids. right? And probably is because of the history of the sterilizations campaigns and all the abuse in the 90s, in which some practitioners are more aware and understand that they're still in trial, but the fact that they're still in trial is that it's not completely accepted that that shouldn't be done, right? And this quote also acknowledges that it's still happening. Other type of cases of violence has to do with who makes decisions in the situation in which you might be encountering some problems. So this is a doctor, again, that says it's a problem with a woman with complications, and they have a very in early pregnancy. So she mentioned that the baby was 2 kilos. So it was really small, and he wasn't sure of having the delivery, but the women keep coming with complications. So he said, okay, I had to make a decision, but I wasn't going to make the decision alone. So he talked to the husband, right? And he asked him, and he said, okay, if I operate now, I will save your wife, but I'm not sure will happen with the baby. But if I don't operate now, both will die, right? So those are the chances. That's my recommendation. You decide. Obviously, the husband accepts what the doctor is saying, and he decides. But what strikes in this testimony is that the doctor have a strong explanation and justification for why not asking the women, right? And he says, I have not asked the lady if she wanted it or not. Why? Because she's going to fight to the last for her son. So she's sacrificing herself, and that's not right either. But let the husband also bear the responsibility. Right? So he asked the husband to include him in the decision and make him responsible, but it's completely ignoring the women as a subject in the process, right? So to make the husband more responsible, more involved in the pregnancy, in the future, etc. So all that sounds fine, right? But the other problem is still there present. Then another type or example of how violence transmits in the experiences of the professionals has to do with this quote, a term in relationship with technology. So to some extent, midwives, obstetricians said, okay, the companionship that the women want has been lost in the process of, for example, monitors and all the tools that we have to take care of them in the process, right? So he said before you had a resident that had to be sitting with the pregnant women and accompany her the whole process and make sure all the checkups and the controls were taken care of, right? And apparently you assign one person to that woman, and it's in a case-by-case basis. With monitors, she says, we plugged the monitors in, and then we lost all the contact and the communication with them. So we start we think that within the regular practices, in some cases, they become aware of how these practices might be affecting perceptions of women, but in many of them, they're part of the regular practices and not even considering them problematic at all. Here, what I discuss a little bit or try to incorporate with the literature, for example, about authoritative knowledge, and how that helps us understand the loss of autonomy in women in the institutionalized setting, right? And there's one quote again here that said that women don't understand what's happening to her or in the care provided, right? And needs someone to explain it to him, right? Because she's going to be afraid, because they might have other beliefs and myths, right? And what you need during pregnancy is to have information about what a normalcy pregnancy is, what the possibilities of risks are, what complications, how to take care of yourself during the period prior to the delivery. Yeah? So all the explanation comes in the moment or in the process of taking care of the pregnancy, not necessarily in the delivery itself. Once you become in the delivery, now you have to follow the indications that are being transmitted to you. So what decisions can women make in the process? And sadly, very little, right? So doctors and health practitioners in general acknowledge that mostly they have to decide or accept to follow the recommendations, right? To be obedient or to collaborate, right? They decide to collaborate or not collaborate in the process, to follow or not follow the indication. They have to accept the prenatal control checkups, the guidelines during the period, the training to have a healthy delivery, etc. But when they are in labor and in the delivery room itself, most of the decisions are taken by the health practitioner, either the midwife or the doctor itself. So it says that is basically what one explains to her and gives her the recommendations that this must be done. But in 90% of the cases, the one who has to make the decision and sign the consent is the patient. Except, right? So we tell them what to do and they accept and they agree, but with no other option to some degree. So we think about reproductive governance to understand these processes. We have again another set of issues, right? So what can the women decide? And again, practitioners said, okay, she can decide to become pregnant or not, right? Before coming to the institutional setting, when we have the control, right? So several of the testimonies mentioned, yes, they have to decide, they decide to become pregnant. Right? However, that's also tricky because they don't necessarily have the options to change the situation once they're pregnant, right? So there's a quote here too that says it's a case midwife that's taking care of adolescents and young women, and she said, I've seen a lot of women with 15, 16, 17 years come in with multiple pregnancies, so but I cannot tell them much at the moment because I was assisting. I'm not the head of the room or in charge of the room. But she said, if I were a professional in charge, I would ask them, right? She said, how are you doing? In the sense of, are you with your pregnancy? And she mentioned, because what we do is, you come, you meaning the women, right, come with your positive test to the hospital, and we said, okay, welcome, right? This is the line for prenatal control, and then begin the whole process of this is your delivery plan, and these are the nutritional recommendations, etc. Right? So we start directly with the guidelines and the plan. So there's no moment in the process in which they might be able to think about the decision once they step on the health facility. Right? So just to finalize some of these ideas and experiences, what I find is that most of these experiences interconnect or have in common that they relate to failure to meet professional standards, right? But at the same time to the type of violence identified as a poor rapport to women, the lack of communication, the ineffective the transparency about the processes or the communication process itself, and the loss of autonomy, which is also part classified in that typology, right? So we have an concentration of bad experiences and violent experiences that combine these two aspects specifically. From the point of view of the health practitioner, right? The other cases, other type of violence are probably there, right? Any women might be mentioning all of them, or other in higher priority. But from the perspective of the health practitioners, those are the two that seem to be happening more, or that they are aware to some extent that might be happening. So just to finish a few steps, what to do with this, right? A few steps forward. And what I think is that one of the issues that is being, or one of the approaches that is being developed also in recent years has to do with the humanized approach to delivery. Different, it's not a unique body of literature or characteristics, but at least have some elements that acknowledge the need to communicate, to make closer relationship within the doctors and the women, and make women central to that process. I think it's important to include health practitioners in the discussions. There is a lot going on and a lot of improvement from the feminist activism and advocacy in terms of rights, a lot of empowerment from women that are more conscious of what to demand, right? But we are still encountering a wall in the other side, so we need to include more of the health practitioners in this. And then we might discuss how medical institutions and hospitals are being organized, and how training to medical doctors and midwives and health professionals are also being reproduced and continued. And we also, of course, have to continue and stress an advocacy for women to continue pushing this agenda from outside the hospitals as well. So that's my presentation, and I hope it
Thank you so much. Thank you. This was super interesting. I'm sure that there are plenty of questions, comments. I have several. And why don't I kick off while everyone else is thinking about about their questions? Sorry, I'm not going to stand the light yet. So there's a lot of rich information here about what the health practitioners say and what we imagine the women. I know that you've also done the interviews with the women and what is behind there. I guess that there are a couple of sort of what you've spoken about less, and perhaps it's interesting for the audience to hear a little bit more about that there are very structural problems here that are very difficult to address. No, it's not even only about advocacy for women's rights. There's very clearly a racial element here and a class element that is almost impossible to address through working with health professionals. So so that's on one hand. There's the structural inequality based on race and class, and then the other very frustrating element in this that is so difficult to change just by working with health practitioners is the issue of reproductive rights. No? But what struck me in your presentation and what people are saying is that how easy it is to just propose to tie the tubes. How easy it were to put in semi-permanent contraception in women's arms, and all of that is easy and accepted and widespread, and but you can't comply with a request for abortion of a 13-year-old raped child. No, so these contradictions in Peruvian reproductive healthcare settings are really frustrating, and I think that they. Well, I guess the question is to what extent do they influence the agency of the health practitioners themselves in how far they actually in how far are their decisions made out of knowledge and agency, or are these decisions that the health practitioners make also very much structured because of those political, institutional circumstances and context?
Mm-hmm.
I guess that's my question, opening question to you. And Jasmine wants to follow up on that.
Wait, before I follow up, that microphone is not connected to the Zoom, so I just want to check that with the people online. Do you know?
Yeah, it should be.
At the beginning it was.
Yeah.
Okay, because it says here the digital audio. If you could fix that,
okay.
because the people
Let me
online
move.
can't hear you.
Can't hear me.
Yeah.
Really? It was connected.
I can move from here.
Yeah, that's the one. Can you hear us on the Zoom? Not that. Can you hear us now?
When I speak, yeah, because I wonder if they hear you now.
No, it shouldn't really. No, better. I think they
But
can.
if you
It's
can,
quite
can
close
you
up here.
stand on the other side of the room and see if they can still hear you?
Can you hear me now, online? If I speak like this?
More or less. Yes.
Yes.
Okay. Excellent. Yes.
It's a bit.
No, we can't hear, yes. Okay.
That's all right.
Okay. Thank you so much. Jasmine, did you want to follow on that?
Yes, thank you. I agree, it was really interesting and lots in there. And I guess my question is linked to Jelka's in that, I guess, how do the sort of structural inequalities that frame the whole health system come into play? And, did you see that some of these were more prevalent, some of this violence was more prevalent in the public or the private sector? How did that play out? And also, I guess, another part of the picture, which arguably is linked to lack of reproductive rights, is the really high incidences of C-sections in Peru, which is not all about women's choice. So kind of, I guess, that whole picture that is all interconnected, how does what you're finding sit against that broader context?
These are two very big points, so I'll let you answer before we
I have this.
Oh, you have one. Yeah.
Okay, yes, thank you. Thank you. In terms of private and public differences, there is some differences. But, of course, being private, a little bit better in terms of what women can demand, but that also will change by class, right? Because there's a lot of private centers that are for middle, lower income classes that also have some problems in terms of the recognition and acknowledgement that they give to women, right? So many people go to private centers when they can, but in many cases when there's middle income and lower classes, those clinics don't have all the resources when there are complications. So they end up in a hospital anyway, because they are transferred from the clinic to the hospital. Most practitioners that work in public hospitals also work in private clinics as well. So their experiences of violence are mostly recalled to the public places. And of course, many of the justifications or the explanations of why these cases take place has to do with limitations of the center, right? Some cases they mentioned and acknowledged that they have 16 hours shifts or 30 hours shift, and laugh about saying, okay, you don't want to get to my turn when I'm done because I won't be being nice. I want to go home. I don't want to start a procedure now. I haven't included all the cases, some of the cases of abortion, especially because that opens a lot of other issues, but it's very telling that, for example, when women get to the hospital for an abortion, they are automatically put in the waiting list, at the end of the list to be attended, right? So, and they said, of course, you have to prioritize the live baby that is going to be delivered, right? She can wait. And explicitly saying that if there's a change it's 1 hour before the change of shift, they will clearly not include it in that shift, will wait until the following shift, because nobody wants to start working or doing anything, and an abortion case is not a priority for them, right? So even though they recognize they have rights, but they said, okay, we're tired and it's not, I have to work and my work ends at that time, and then it's not fair for me to stay longer for any reason. So that about the structural changes. I think it's very important to consider the pressure also of the developmental approaches and goals, and that's what I mentioned it also at the beginning. They set the tone for the health policies in Peru, and they continue to be very much organized in terms of meeting the international standards, reaching indicators, and showing the results that they want. So that also contributes to diluting the presence of women, of the body, of the individual to some extent that are being taken care of. That demands a different approach to change and to advocacy and to keep fighting, right? But what and also pressures the health practitioners and limited their agency, as you mentioned, right? But recognizing, or what I like is that many of them recognize that they are able to identify when they're accepting violence or hurting or some kind of abuse in their practices, and to some extent they might be able to change it, right? Not in terms of what the resources they have, but in terms of, for example, the emotional component or the parts of the interrelationship between the women. I will hope, if you make the relationship about individuals in the specific context more evident or more valuable, that could also contribute to improve that relationship. What I think is that in parallel of getting all the norms or the guidelines or the legislation, that it's important to hold accountable and demand the exercise of rights. Also, something at the micro level needs to change in the meantime, or we need to start trying to move pieces from there too, because the going down of the normative and the legislation, what ends up doing is creating a defense and demand and frame the discourse and the narratives in terms that I know it's wrong, but I have the legislation that allows me to. Right? So how to play with those conflicts that we have. It's something that round in my mind all the time, and thank you. But thank you.
Thank you so much. Can I just, before I come to you, because Avril, do you want to just ask your question to?
No, she said. Okay.
If you can hear me, Avril? Why don't you ask him? Yeah.
Yeah, okay. Well, I'm in a public place. Okay, I will try. Can you hear me well?
Yes.
Yeah.
I was just wondering about litigation. In Mexico, there was a famous case of a few indigenous woman, Oaxaca. She won, it was a very important litigation case in Mexico, and she won everything that she claimed for, but there was really no a way of looking after, after the years passed, the court ruling was not compliant. So, and the health system, it didn't have a lot of effect in the health system. So, I was wondering if litigation is coming in Peru, or if the doctors or other medical staff were aware or worry about litigation in cases of obstetric violence.
There's not case. Well, there have been few cases of litigation on the Inter-American Court, but they were like 2 or 3 very emblematic ones that were assumed by women's organizations and feminist groups that pro bono made the case, right? But it's not part of what regularly takes place. So practitioners said that they are afraid of litigations, or they are afraid of the claims, but most claims become part of the reclamation book and are registered in the health within the institution, right? And those processes can take us longer and are not clear what is actually sanctionable within the health system, because the legislation is not clear or not accepted as such as the clear. So women will have to take the case to the civil court, and those cases are really, really 3 or 4 in the whole decade.
Thank you.
Thank you.
Thanks. Can you hear me? Sorry. Yes. Yeah. Does that work? Yeah. Sorry. I really loved your talk. Thank you so much. And one of the things I found interesting about it is that it chimed with, and also was a little bit different to research I've done in Zambia on how institutional rules about the rules that women are expected to obey during pregnancy and childbirth end up leading to disrespect and discrimination and inequalities. And so I wanted to ask you, in terms of the drivers of obstetric violence, sort of we've focused more in the literature to date on, both interpersonal aspects, the fact that health professionals are tired, as well as limitation resources at the health facility level. But what about the stuff that is working, and that is working to, inflict violence upon women? And of course, you gave many examples. Like suicide, but like also episiotomy, the fact that women are expected to lie down during birth, and all of these practices which health workers will use their authoritative knowledge to impose on women. So there's this, as well as the sort of structural inequality in power by gender, class, and race, there's also that power inequality between patient and health provider. And how interesting it is that, they say it's biomedical, but actually, rules about what is considered biomedically optimal in childbirth change all the time, right? So we're now revising standards around episiotomy, around walking around during childbirth, etc. And I'm just wondering, therefore, and actually this chimes with the question I can see from Rebecca Bryany there around the whole thing around failing to meet professional standards of care. Is it actually about, reviewing, not just failure to meet them, but actually reviewing the standards of care in the first place? And will that make a difference, or can we not make a difference until we reassess the power relationship between, providers and patients? Sorry, that's
Well, it's a very good question, a difficult question as well, because I think I agree they need to be revised because the medical practices change over time, but those revisions need to reach the huge amount of, the huge number of health practitioners that are not connected to educational settings anymore, or to training. So those structural problems in the health sector also affect the way in which the health professionals become actualized in their knowledge, right? So that's a gap there as well. And the power relationship is, it's gonna still be present, right? Because there is a knowledge that finally the increased use of technology and medical practices put us women farther from the practices that the knowledge that doctors have, right? So again, there is a movement there, or a claim can be made of to what extent delivery needs to be that much medicalized in the first place, right? Which is also another trend that's been pushed away, right? So maybe this revision of the practices might lower the intensity of the intervention, the medical interventions, and then you could claim that women do have some knowledge about their body, or how you teach about within women groups how to know your body, right? We were talking earlier how women's organizations, local women's organizations or grassroots organizations and feminist organizations more recently become a place where we can discuss our own problems and share experiences and then learn from each other and get some idea that we can then claim and say like, no, I heard that somebody did, right? My friend passed through the same and they didn't do that. They have to do something, they could do something else, right? But there's also networks that need to be also developed and empowered so you can balance knowledge to some extent. Yes, yes. So that could be very useful as well.
Anyone else in the audience?
There's more questions.
Yeah. Can you call out who's?
Yes, so let's go back to, so we've done Abril, right?
Yep.
So Susan, and there's one in the Q&A too.
Yeah. Susan, would you like to speak to your question? Or your comment, really? Autonomous women's movement, or would you like me to?
I can't hear a thing, but I did hear the word Susan.
Can you do you want to speak your question? Can you hear us now?
No, I'm enjoying writing in the chat. I haven't got a particular question. I love everything Ruth is saying.
I think you're mentioning about the women's movements or autonomous movements promoting home deliveries or safe deliveries in outside the hospitals. There are in Peru some, but they're very much middle upper class organizations of women with more knowledge, education, resources, and the security at home to be able to choose to have the delivery at home and the ambulance to go in case there is an emergency, right? So they're still very much reduced and limited, and they're not encouraged because by law deliveries need to be taking place in an institutional setting, right?
Great.
So
Rebecca Ryoni, do you want to speak to a question?
Yeah, I'm happy to speak to it. Can you guys hear me?
Yes.
Brilliant, thank you. And I think there have been some comments in the chat, but I'm not managing to keep up with both. So yeah, thank you, Ruth, there, just a fantastic presentation. But I'm really interested in this point about the things that healthcare professionals describe having to do and the extent to which these are things that they have to do because that is how those are things that the law requires or that are required such, by sort of practice frameworks such that they are at risk as clinicians if they don't do them, or to what extent this ideas of things that you have to do come from sort of norms and informal standards of local professional practice. And I think sort of what is sitting behind this is, we have things in the UK context in which I work where people will say they had to do it, but actually that's just how a certain set of guidelines has been sort of commonly interpreted. And we also have a history where medical negligence law relied on sort of what other clinicians, what other doctors thought was reasonable practice. So I guess I'm interested when we're then trying to sort of map these things against a typology which is talking about a failure to meet professional standards. That definition of, I guess, who's interpreting, who is defining professional standards. And I guess there's a simple answer from the sort of foreign perspective, but I think it's much more complicated when you then start to interpret it and try and use these ideas within different practice and jurisdictional contexts. So that was a bit more complicated than what I wrote. Does that make sense?
Yes, thank you. No, and it's very, very interesting because, again, I think there's a really important gap there because the typologies and the way we've been discussing about obstetric violence comes from the experience of women. And for example, and we need to see what are the health professionals or the medical field finally acknowledge or makes of it. Because, for example, the failure to meet professional practice. Who defines professional practice needs to be the practitioners, right? And they need to acknowledge what are their practices first and how their practices might be, right? What's the extent to which they are doing it because it's part of the practice, or overdoing it, or again doing it less than it should be done, right? So that's a dialogue that's still present, and I thank you for your question because it's something that we still need to engage on to find out some common ground and points in which we can move forward. And I wanted to say something about that many of these issues remind me is that the idea of the rights that we have in Peru, that women's rights have, and all the legislation and the rights to have access to different issues, it's to some extent understood in some cases as an obligation. So health practitioners in this case, if they have the right to life, they will make everything to save the life regardless of any other situation, right? That's a problem because when you then start talking about new legislation about recognizing the rights of the unborn, and then it comes a challenge, then who rights over comes the other one. And again, in terms of what are the indicators that they have to meet, and if the law says they have the right to birth control, or if they can be used in terms of is their right, they have to, right? It's not like it's your right to choose if you want to. You don't. I don't know if I can explain this right, but it's like you have a right and you can decide if you exercise the right or not, right? But that gives you the autonomy to exercise your right or not. assuming you have all the access and everything there. I will say that in Peru it's also present the idea that if you have the right, it becomes an obligation. And that's challenging in many other aspects of the reproductive health umbrella and the fight for rights that women start, though, because all the campaigns for the right for abortion. So people think, okay, if you have the right for abortion, then if you want to, you will have to have an abortion, right? So you open up the possibility that people do more and make them do it, because it's a, I don't know, confusion of terms or interpretation of the right as I'm thinking now out loud, but might have to do with, a similar example would be the right to vote. Like we have the right to vote, but voting in Peru is compulsory. So we do have to vote because it's our right. And we are fined if we don't vote, because we have the right to vote, so you have to vote. So if you take that analogy to other rights, it's like suddenly they could make your right an obligation, right, and fine you. So, well, that's another discussion for something else, but it's
super interesting to think about the autonomy and the agency that people have. It's an
when you talk about
rights,
right,
where people feel that they have to do because, without thinking themselves necessarily. Very interesting. Yeah. But I'm going to take the two more questions online. Anything from you guys? So we have Lucy and Kiersey. Lucy, do you want to speak to your question on traditional midwives?
Sure. I think my question was mostly answered. I was just curious about the prevalence of traditional midwifery and their relationship to the hospital, but I assume that they're deep underground and marginalized and not public facing in light of that law. So thank you for your work. It was a great presentation.
Yes, traditional midwives are not part at all of the health system. They still very few in very rural communities in the Amazonian or the Andean towns, but there's been few movements in different times to make them visible and incorporated at least at the local level when they're not doctors and not qualified midwives. But part of the campaign against maternal mortality was also to reduce or eliminate or neglect the role of the traditional midwife. Yeah.
Kiersey, you wanted to ask a question about the role of different professions. Do you want to explain what you mean, what you're thinking of?
Yeah, thank you. Thank you, first of all, for the very, very interesting, enlightening presentation about the situation in Peru. I'm just thinking about the way in which humanization of childbirth has been happening in many countries. That there's been, and you also alluded to in your presentation, to some conflicts between the different professions, options and midwives, I assume, that different professional organizations have taken a different stance on this issue, and in most countries, midwives have been the ones standing with women and demanding humanization of childbirth practices in hospitals. I just wanted to hear a bit more about where this is, or how this situation is in Peru. Thank you.
Thank you. Yes, midwives are promoting and encouraging the discussion on humanitarian births, but there is very little actual progress including them in hospitals and in institutional settings. There are few, like maternity, hospital specialized on maternal care. There's one very big one, important in Lima that claims and have improved their practices following some of the guidelines. But most of the aspects, well, the main aspect that about the humanitarian delivery of humanitarian birth is the accompanied birth, so that people are allowed to have a member of the family with them. So that's the element that most health practitioners recognize as part of the humanitarian approach. So let them be accompanied by somebody. They acknowledge it, but hospitals, because of structural issues and the number of people that they have to attend and the space, that not allow them to do it. So the protocols have not been updated to incorporate that. But it's mainly about being accompanied during pregnancy, about being able to choose the position in which you want to deliver, and about to have a pain control. Right? So those are the three elements. I know that there is one hospital that takes the effort and follows and complies with that. The other ones are unable to do it in terms of not having a space or not changing their own protocols. Each hospital have their own protocol. They don't have enough anesthesiologists, so most public hospitals don't provide epidural or anesthetics for women. The company can come and go for brief periods of time. There's been a very strong effort and movement to facilitate the vertical delivery and the positions. And there's been a lot of investment in the new beds or chairs for that, especially in rural areas and in hospitals in outside Lima, in the regions. So, but there's still not a lot of usage of that, right? But that's been what has been like promoted, and important guidelines about allowing vertical birth with the framework or under the framework of intercultural health approach, not under a humanized birth, which makes again a break between who has access to an intercultural birth, people who are from the Amazonian, who are Indian, from Indian ascent or ascent, and not in the big cities when you are supposed to be not indigenous. So that the discourse changes in that way if you frame it as a vertical intercultural policy and not as a humanized birth for everybody. Right? So thank you for the questions.
Thank you so much for your presentation. Very rich information, great answers, great questions from everyone. Thank you very much online for all the information and comments in the chat as well. We are reading you all, so great, and thank you so much for your participation. I think we're gonna have moved to the next room for some drinks and nibbles. And the next seminar is on the 11th of May, I think, yeah? Who's speaking? Sorry? You're speaking. Welcome. Excellent. Fantastic. So next speaker is already here for the 11th of May. Thank you very much, everyone, and see you next time. Online, in person. Thank you.
Thank you.
Thank you.
No, thank you.